Good evening, everybody. I'm Hilary Lindsay, the Chair of CLL Support, and I'm absolutely delighted to be welcoming you to our first PPIE webinar, where we're going to talk about the theory of public and patient involvement and engagement. So I just want to begin by recognising the financial contribution that we've had from the following pharmaceutical companies towards the costs of our webinars. They've had absolutely no input to the content of the programme or the choice of speakers. They provided monies used towards the cost of the webinar licence, administration, and to making a professionally edited recording available on our website. So thank you to AbbVie, AstraZeneca, B1 and Lilly. So this is what we're here to talk about this evening. And we recognise this is very much a topic that may be a bit close to home for some of you. It can be an emotional burden to get involved in PPIE. So if at any time you feel this is too much for you because you're also a patient, then please just leave the webinar and let us know afterwards if you want us to talk to you about it. So our contributors this evening, we've got a fantastic combination of clinical experts and patients. So we've got Dr. Nicholas Martinez-Calais, we've got Dr. Ben Kennedy, we've got Jackie Martin, and we've got Troy van der Leel, so 2 patients and 2 clinicians. So these are the topics that we're going to be covering this evening. We're going to look first of all at setting the scene, then we're going to look at the participant voice, then at clinical trials and the scope of PPIE, understanding and empowering PPIE, and then the research application framework and some PPIE resources. And then at the end, we'll have some Q&A. So the first section, setting the scene, I'm just going to talk to you very briefly about. So when we started off working out what we could do about what was good PPIE from the point of view of CLL support, there were 5 of us on the group, and each of us came up with a topic that we thought was really, really important. And collectively, we came up with what we see as our hand of what we see as important from our side of the situation. And so feel it's very important that PPIE is embedded and costed, that it's a respectful partnership, that there's effective communication, that it responds to patient need, and that it encompasses quality of life. And having come up with our 5 fingers, we then decided we'd have a framework it would fit together in. So this is our STAR group. So STAR stands for Studies, Trials and Research. We've got an acronym here. And this is what we've been doing at CLL Support to try and make sure we're being more proactive in this whole space. So we're looking at informing you all, we're looking at promoting what matters to you, we're looking at connecting with others to make a difference, and we're looking at convening and involving our members. This is a really good example of how we've been convening and involving you all. So earlier on this year, we set up our PPIE register, and we've got over 130 of you that have already logged on to that, shared some information with us about yourselves, so that we can come and ask you for input. And if any of you want to know more about STAR or to join the PPIE register, there's a page here on our website you can go to. And this is actually the launch of the page. We're just making it available now. So it's fantastic that you're able to go and find out more about that. Just wanted, when we ask you to join the register, we ask you to tick one of 3 areas where you can get involved. You can tick all 3 if you want, but you may choose just to tick 1 or 2 of them. And so one of them is about being involved in discussions around research activity. The second one is about PPIE activities related to our condition, CLL or SLL. And the third one is in replying or helping us respond to requests from pharmaceutical companies or other organisations. So 3 different ways of getting involved. And if we look at the first area, we recently asked you for your input about fatigue, and 70% of the people we asked replied, which was fantastic. The third area, the requests from pharma companies, we'll continue to seek your input. But this webinar and the second webinar are about area 2. These are about where we're getting involved in very specific patient and public involvement and engagement activities, and where you might need to know a bit more about the background to them all. than just joining in, if you like. And so that's exactly why we've got these webinars, why we're recording them, and why they'll be available to you. If I can now hand it over to Dr. Ben Kennedy, who's going to talk a little about the participant voice.
Thank you very much indeed, Hilary. My name is Ben Kennedy. I'm a consultant hematologist, and I've been working with people with CLL for a very long time. I'm delighted to be here today, and thank you very much for joining us to talk about PPIE. We're going to talk about the participant voice and keeping patients at the center. So next slide, please. So just going through some of the basics. As a member of one of the research ethics committees, I've seen time and time again how PPIE can help improve the quality of research and can make it easier, much easier for participants to engage in research. It sounds very daunting for PPIE, but it really isn't. And in many ways, it's so important to know that there is no technical or medical knowledge required. There's no special qualification here. This is all about being sensible and about helping make things clear and transparent to people when they're considering a clinical study, so potential participants can make informed decisions. Sometimes there's something really obvious, and hopefully this webinar will go some way towards empowering you to identify some of those elements that might need simplification or clarification. And quite often, it's something very straightforward. It involves questions around who or what, where, when, so how something is going to happen in a clinical study. And if a point gets missed out and you spot it, it's the elephant in the room, and you can address it. And it's about that level of sense check when it comes to engaging with the participant supporting documentation, for example. We'll talk more about that. So research is something that happens because people will engage with it. It's something that happens with participants. It's carried out by the participants. They are partners in this. It's not something that happens to or on people. It's not a passive process. And really, there are three key pillars here. Firstly, making sure that participants are treated well with dignity and respect. And I think the main one there is about the caring. Research is about making things better fundamentally, and therefore it should at its heart be caring, and people should be looked after and cared for as part of this. Usually a clinical study involving patients and participants, it could be about some kind of treatment, and that needs to be a caring process. Research should be meaningful to the population affected by a condition such as CLL. So the CLL community, and that means the patient community, should expect that something will make a difference ultimately to them. We don't always know what that difference would be. So it needs to be something that is relevant, and that can be helped shaped by good PPIE. It can also mean that the barriers to recruiting to a study can be addressed, and when things are made clear and transparent and as simple as possible, that it means that people are more likely to engage with it. It's all about choices. It's all about understanding what avenues, therapeutic avenues, for example, that it's possible to take. Next slide, please. So everyone has got something to say, whether you're newly diagnosed and started active monitoring, or whether you've experienced multiple lines of treatment, for example, over a period of many years. And the key idea is that a PPIE group, patients, caregivers, health service users, is representative. And it has diverse understanding of what is broadly important and relevant to the CLL community. So all is required is that common sense approach, addressing things such as jargon, spotting that, encouraging plain English. So what an amazing opportunity to build that supportive relationship with researchers and help keep patients at the very heart of the research process. Next slide. The National Institute for Health and Care Research tells us they've identified 5 key areas, core principles, if you like, to guide us with this. So firstly, sharing power, making the relationships one of reciprocity, give and take, to include all the perspectives, respecting the values, the knowledge, the experience of people on all sides, all aspects of the research, the researchers, the participants, and the PPIE group. And then building and maintaining that relationship over time, helping to communicate results, for example, and to celebrate the dedication of patients and their families and carers who go into clinical studies in the first place. And now I'm going to hand over to my colleague, Nicholas Martinez and Mrs. Jackie Martin for the next session.
So we're going to start with this part of the webinar, which is basically there to try to give a flavor of what's behind the clinical trial and some basic information about clinical trial to prepare people on the register that may want to be involved in this. So you'll be delighted to know I'm not going to show you too much sort of statistical or mathematical or survival curve information. And we're not going to talk too much about CLL really, because this is meant to be very broad and overarching, and it should be applicable to any sort of clinical scenario. So I'm joined by Jackie, and I'll ask Jackie to join us and give us her perspective as we go along. And the purpose of what I'm trying to do here is to try to engage people and make you hopefully interested in what it means and the background of the clinical studies. So why do we do clinical studies? I refer to Ben's statement before. That's that trials are made for the patients and to answer a clinical question for the patient. So these are 4 pointers that I think are very relevant, and they should be kept in mind whenever one is supporting the development of studies as a patient representative. So we aim for a trial to answer a specific question, and there usually should be one question, and that's kind of the as you will, the elephant in the room sometimes to ask is, what is this trial trying to answer? And if the people conducting this trial are not able to answer this clearly, then there's a problem. Sometimes there might be 2 or 3 questions, and that's a matter of efficiency, because if you're going to invest significant amounts of resources in a trial, sometimes it's useful to try to answer more than one question, but these are usually secondary. There's usually a main one that we'll get an answer from this study, and that should be always something that you should be asking yourself. The other objective is that the results are reproducible, and that's overarched or underpinned by the good clinical practice, which is a set of rules and a set of standards that should be met in every clinical trial. And the purpose of those is that if I conduct a trial here in the UK, I've got enough information and I've got enough documentation of everything that has been done, how has it been done, so I could take this trial and do it anywhere else and hopefully reproduce these results. Sometimes that may not happen because of other factors, but ideally I should be able to do this trial exactly the same anywhere I go. The other objective is that the results are generalizable, and that means that, as it happens with a clinical trial, we cannot trial a new drug or a new combination of drugs in the whole of the patient population. We're constrained to do whatever design to to try it on a relatively finite number of patients that will allow us to make that result extrapolable to the whole of the population. And that means that the population that is included in that study should be representative of the whole of the universe of the CLL patient population. And that has many aspects to that, as where is it conducted, so what's the nationalities and what's the racial background and the ethnic background and the age and all the demographic characteristics of the study that will make it representative of the CLL population. And the other one is that the relevance. We're fortunate to have a very rapidly evolving scientific field, but that poses a big risk because sometimes the studies need to be keeping up with that evolution. And sometimes if the trial is not designed appropriately, then by the time the trial results come out, they might not be relevant anymore. And that's also a good question that can be easily asked. Are these results going to be relevant by the time we hear about the results of this study? So four very critical questions that as a member of a patient representation in a study, you should be asking. Why do we do the research then? So ideally, we want to improve patient survival, although, as you probably have heard with different sources, that the treatments for CLL are very good, and the survival of CLL patients with treatments are very close to the survival of the general population of people without CLL. So then survival is difficult to improve already because it's already good. And then the surrogate of that is then that we have to improve quality of life. And by improving quality of life, it means that we have to get people to good eradication of the disease for as long as possible. And that's what we traditionally call the progression-free survival, as one measure of that. Which is slightly different, because if you move this context to, for example, solid organ malignancies, lung cancer, pancreatic cancer, then survival becomes the main goal. But CLL is very particular because of that, and therefore we are aiming at these particular aspects. We've got several actors here, two more, yeah. So we've got 4 different actors here that are involved in the clinical research: the clinicians, which are the ones that conduct studies; the funders, which are typically pharmaceutical companies, but not always; the regulators, that are the ones that dictate that the trial is conducted, as said before, with dignity and respect for the patient welfare; and the health system, which is where everything happens, and patients and carers, and should be in the center, as it's depicted here in this graph. I want to give maybe Jackie some time to perhaps give us our her testimony from the point of view of a patient representative, and what has been her experience.
Trials, honestly, so important for patients. Personally, I've been in several trials. I think without question, it has always been a good experience. The mention of respect and dignity, clear patient information, knowing all about, or as much as you possibly can about the trial before agreeing, so that you can give properly informed consent is absolutely crucial. And I've never found any pressure to enter a clinical trial. It's always been offered to me because it's been felt that it could offer a definite benefit, and of course that is perhaps a treatment that you might not be able to access normally within the NHS. The first trial I entered as a patient was the FLAIR study, which was comparing originally, in its original form, was comparing ibrutinib and venetoclax against FCR, fludarabine, rituximab, and cyclophosphamide as the standard of care treatment. I had 6 years of treatment on the FLAIR study and did very, very well. I was very grateful for that treatment. I think we have to, as patients, we sometimes have to understand that not everything, because some of these drugs have not been tested in large populations of patients, that there are risks and benefits that may not yet be known. And certainly in the case of ibrutinib, I think it wasn't until this very large scale study was done that the risks around cardiovascular problems of hypertension and atrial fibrillation were known about. So that wasn't necessarily what the trial was looking to, to examine, but it was a very definite outcome. And obviously, since then, we've had newer drugs come along which have had a better toxicity profile in terms of cardiovascular risk. Patient information sheets, that's where patients getting involved in the sort of early stages of a clinical trial can make a difference. They can be quite wordy and weighty, and patients can help with the design of those patient information sheets so that the information in them is more accessible to patients, that patients can, so that they can understand the information more clearly, know exactly what is or may be asked of them in terms of logistics, in terms of, how am I going to be seen? Where am I going to be seen? When am I going to be seen? How often am I going to be seen? What additional things will happen to me that might not otherwise happen to me? Those are all sorts of things that patient involvement can influence, and put the patient perspective over. It's most trials are delivered locally, so they will be at your local hospital if they're involved in research. Some smaller hospitals are not involved in research, and you might be asked to go to a slightly bigger centre, a university hospital or something like that. When my CLL relapsed, I actually took part in a study of a bispecific antibody. I was only the 6th person to take part in that study, and I travelled to London every week for that study, and even had to stay overnight on occasions as well. I was also attached to a pump for 24 hours a day, and so the logistics of that clinical trial were much more onerous and much more difficult, although not unwelcome, because I really wanted to give this new drug a try. Very different to the situation I'd been in at my local hospital, where it was very easy to access things. I knew the research nurse. I think actually I probably should mention the research nurses. They're really important to patients in clinical trials, because they're your go-to person, if you like, if you've got any queries or concerns or anything like that. And they're generally always available to talk to you or see you in person if you want to, and probably you would see them at every visit. Often with clinical trials, you'll find that you might need to have a few more blood tests, a few more CT scans, and again, the patient perspective's there. Do you in terms of the design and input into the trial, is that something that we feel that patients would be happy to accommodate in view of the potential benefit they're going to get? Do they want to have the CT scans and the risk of tiny additional risks of the additional radiation? Because those things are important for the clinicians to be able to document and evidence the fact that you're in remission, or that you perhaps unfortunately have relapsed and have now got progressive disease.
I was gonna interrupt you, and then maybe perhaps discuss. So it seems that your experience as a patient has significantly enriched your ability to take part as a PPIE in clinical trials, but perhaps just to give people some reassurance that although that is helpful, then
it's
not necessary.
Not necessary. You certainly don't need, as Ben Kennedy said, you certainly don't need a lot of knowledge. You can't say or do the wrong thing, because it is your perspective that you're bringing to the room, to the environment, to the discussion. You obviously try and bear in mind what the researchers are trying to achieve. But if, for example, some of the requirements for the patients are just too onerous, then the trial could fail if you don't, speak up and say that you feel that it is, because, ultimately patients may not be recruited. They may feel, well, I don't think I can manage that, or that, that's a bit too far, or that I don't like the sound of that. And, everybody brings their own, every patient brings their own worries and concerns about their condition too, when they take part in a trial. But you, as a PPIE, have to stand back a little bit and try and think a bit more broadly. Well, how would I feel about it? How do I think the general CLL population, or whichever group it is, population would be able to cope with all those different elements? But no, you certainly don't need any particular experience, just a willingness to want to help and to improve things and work collaboratively and constructively, positively with your fellow researchers, because that's in the end then what you've become part of the research community, and they're a very welcoming community.
Thank you, Jackie. And I'm going to complement that, all the views said with the clinician's perspective, and in two different ways. So the two levels I think clinicians are involved in clinical trials, and those are the ones. The first one are probably the ones that are delivering the study, which are doing the day-to-day visits of the patients, seeing people that comes, consenting them, etc. And as a clinician that does that as part of the kind of routine care of the patient, it comes with a significant responsibility, because you have to be sure that you bring the trials into your hospital that you think are relevant and I think are going to be beneficial for your patients, and you offer them to the right patient at the right time, and that's very important. There are many examples of trials that have been offered to me that I don't think they're ethical, or they don't think they're right, and as much as I would like to the idea of the research question, etc., there's something about the design that doesn't feel quite right to me, and that feels like it would be putting my patients in disadvantage, and then therefore I've declined them. And then above that are the clinicians that actually are behind the design, conception, and management of the clinical trial, and that's probably where the PPIE representative will have to engage more with them. And then again, for them, and as a clinician that has done that, there's also a big responsibility to make sure that the trial is well designed and complies with all these things we've discussed earlier on, but also we'll hopefully share some examples of trials that in which the PPIE input has significantly changed how they've been done, or how they've been conducted, or the impact they've had on their patients. So just to highlight that, for us, from the clinical side, the representation of patients is very important. And the culture has evolved in the last 10 to 20 years to make the patient's voice very, very relevant for this. Next slide, please. So a few myths about clinical trials. So just we've discussed this when we were preparing the webinar. So is there any financial gain for clinicians that do clinical trials? No. We don't gain any the financial benefit that we receive from the clinical trials, and that is basically payments that we get because you're conducting the visits that are needed for the study and reviewing the documentation that is needed for the study. So basically, they're paying for the time of the people involved in this study. They normally go directly to the hospital, then it goes to be reinvested directly on the research and development departments of the hospital. So yes, there is financial gain from offering clinical trials, but that's a financial gain that doesn't go to individuals. It goes to the hospitals to continue doing the research. And there's a structure of a hospital that offers clinical trials, such as the research nurses that Jackie's alluded to before, a person that handle the data, the archives, and etc. that need to be paid, and that's where these people's so wages come from, basically, most often. So the trial is often funded by pharma. The pharmaceutical company has spent usually millions of pounds trying to develop a single molecule that ultimately becomes ready to go into clinical trials. And they do have a commercial interest because they have invested a lot of money into bringing this into clinical development, and they have to recover their investment. I have worked in pharmaceutical companies myself, and yes, there is a commercial interest, but the pharmaceutical companies, at least the larger ones, I can give testimony that they are. There is an altruistic principle behind the development of the drugs because they want to make the people better, they want to cure conditions, etc. The more important thing about clinical trials is that there is the best. It is not perfect. It's not a perfect structure. It's not a perfect system. It has flaws as anything, but is the best way to do this in a regulated way, in a way that probably everybody wins, and the patients win, the clinicians win, the hospitals win, and it's kind of symbiotic relationship. So basically, what I'm trying to say is that the patient representatives now have a strong voice, and that strong voice is there to regulate and control the funders, to make sure that they give the money to conduct the clinical trials to the most relevant ideas and the ones that are going to give the most benefit to the patients. They are there to regulate the ethics committee to ensure that the clinical trials are conducted with respect and dignity to the patients, and they're there to control the regulators as well, to ensure that there's control over the clinical trial conduct, basically. So these aspects that we alluded before as the main things that you need to ask is just in these last 5 minutes, I want to give you some maybe practical examples of what need and why are they important, and maybe some down-to-earth examples of clinical trials. So reproducibility is something that we alluded before. So basically is being able to do this trial exactly the same somewhere else, and that has is underpinned on something that's there depicted in the middle of the slide, which is the protocol. So basically, every single clinical trial has a very long document as the protocol that includes all the criteria and of which patients can go in, and all the assessments and every little detail of what's going to happen with each of these patients in the clinical trial. This is the key document that's updated regularly, and that is something that you will be asked to review. And it takes a bit of experience to navigate what are the really critical parts of this protocol. But essentially, the job here of a patient representative is make sure that this remains proportionate, and that and we'll touch into that in a moment. And then is this trial, we call this statistical power? So is this trial going to be enough to answer the question that is being asked? And there is a lot of time spent when you're designing a clinical trial into identifying what are you going to ask, which is your research question, A, and B, how big your trial needs to be to answer that question. So there's a lot of time and effort put into identifying how many patients do you need to unequivocally answer your question. And as a rule of thumb, there's more that the differences are between the treatment that is the standard and the one you're trying to investigate, than the larger the number of patients, and vice versa. There's also some other aspects about that, but yeah. So the two clinical trials here that I've brought as an example, the Clarity trial is a relapse study looking at a combination of two oral medication of CLL, ibrutinib, and venetoclax, and the Resonate trial is a slightly older trial which compared ibrutinib against rituximab. So both of these trials have been practice changing in slightly different ways. And we're going to look at examples of those two in the next couple of slides. Thank you. So the next item that you need to ask is, is this pertinent? And the pertinence usually goes in hand with the simplicity. The more simple the question is, the easier will it be to answer, and the more clear will be the answer. So sometimes slightly cumbersome trial designs with slightly cumbersome research questions are usually difficult to read out, and the outcome is usually less palatable. So as an example, the Clarity study, as I told you, is looking at these combination of drugs, but the main goal of the Clarity study was making sure these combination was safe. Therefore, the numbers you need to answer that question is not very big. So this trial was a relatively small trial, but we were trying to assess whether this combination was worthwhile and if there were any issues with the combination. And I think that small trial, answered this question very well. And as a contrary example to this is the Resonate trial, which, yes, it has demonstrated that the ibrutinib worked very well for patients with CLL. It's a traditional study that works, that gave us excellent results for the ibrutinib. But it has compared the treatment with rituximab. And rituximab isn't a very good treatment for CLL. This is a typical example of a trial that has been designed with a control arm that is slightly disadvantageous to the results, and hasn't resulted obviously in a significant improvement. Thankfully, we know how to interpret this, and we tend to look at the results of the ibrutinib treated patients, which we know they're very good, and that's led to a change in the way we treat CLL. But this trial is a perfect example of that situation in which probably patient representation wasn't that strong at the time this trial was designed. Maybe a strong patient representation at the time will say, well, do I really want to be treated with rituximab if I had CLL? So an example where patient representation might have improved. Again, the generalizability, for example, if you did the same trial, the Resonate trial, only on a London private health network, hospital health network, then the results will be completely skewed, and you wouldn't be able to apply that to the general CLL population. And the applicability, so just imagine that we design a trial which I've hypothetically named total therapy trial, which includes these 4 drugs that are very good, all of them very good for CLL, but it becomes very difficult to deliver. And more importantly, if you try to think about the cost of this combination of treatments, will be a cost that is very high and probably not going to incur in significant toxicity for the participants, A, and B, is not going to offer a significant benefit to the patients, even if the cost, regardless of the cost. So, and finally, the proportionality. So Clarity trial, for example, is a study that was looking at the kinetics of the minimal residual disease, so meaning how the minimal residual disease or the measurable residual disease changed over time with the combination of drugs. That was one of the exploratory trials as an example of a secondary idea that can be answered. So if you decided to do this trial and say, okay, we need people to have weekly bone marrow and monthly lymph node biopsies because we really need to get nailed down with how the kinetics of the minimal residual disease works. It is scientifically very sound, probably, but isn't practical because it's putting patients at unnecessary risk and is significantly disproportionate to what a patient would be prepared to be exposed to answer questions that you can probably answer with different tests. So to be question here, is this test necessary? Is this test part of what you would normally do, or is this test additional to what you would normally do? And can this information you're trying to obtain here can be obtained with an alternate means? Those are 2 important questions to be asking yourselves when you're reviewing and participating as patient representative.
Well, thank you, Nick and Jackie, for all those comments there, and you've given us lots of food for thought. I'm now delighted to hand over to Ben and Troy, who are going to talk about understanding and empowering PPIE.
So, hi, Troy. How are you doing? Troy and I, we're going to do a bit of a double act here, and we'll sort of hopefully bounce off each other a little bit. I've got a few slides kind of as sort of aide-memoire, I suppose. And Troy, I think, you're just going to butt in wherever you want to. I don't know whether you wanted to tell us a little bit about yourself, first of all.
Yeah, sure. I mean, my name is Troy van der Lyle. I was diagnosed with CLL quite a number of years ago, and I've gone through one round of treatment. So, but I've never been through clinical trials or anything like that. So when this opportunity came up to talk, I thought, well, I'm the perfect person to ask the noddy questions that people will want to ask, and it's certainly the questions that I would want to ask. Some of them are some of the answers might look familiar to some of the questions which have already been answered, but I think it's important to ask these directly anyway, just so that they're out there, and Ben will tell us that those questions are really important for us, because they are the questions that I would ask. So I'm assuming they're the kind of questions which most people would think about asking as well. But I'm kind of one round of treatment only. So for me, all of this is kind of quite new. And I'm, like a lot of you on the call, I'm on the PPIE register, which has been set up by CLL Support as well.
Fantastic. Troy, can I ask, have you been in a clinical trial, or is it?
No, never. No.
Okay, yeah, cool.
I've gone through, well, one and a bit round of treatments. So that's it. That's it.
So this is kind of moving on to the sort of the empowering stage, I suppose. So nothing can happen without the participants. And so, as we've heard before, it is about asking those right questions. So there's this sort of, I suppose, the rolling program of science and progress, and sometimes those questions pose themselves, and they might be obvious, like treatment A works well, treatment B works well. What happens if you give treatment A and B together? Does it work? Is it safe? That sort of thing. So it needs, the questions that are being asked need to be relevant to the population of people, human beings, that have actually got the condition, and understanding what those endpoints and goals of the therapy might be. So we heard from Dr. Martinez already about things like measurable residual disease. So looking at really, really low levels or even undetectable levels of CLL after treatment. And what does that mean in terms of how people get on, and the ultimate outcomes of survival, and when does CLL, for example, come back again? So
question, sorry, Ben, a question for you there now. So you're talking about finding the right question. Are PPI participants involved at this stage in trying to assess what the right question is?
I think good PPI should probably be involved at that early stage. If it's nudging researchers towards making that a better question. I'm trying to think of an example. I mean, what, for example, if a study was limited to people over the age of 50, for example, or if it was, only in one centre, a PPIE group might say, well, hang about, it should be for everybody. It should be for, challenging the barriers to a study at the very outset, as well as, making sure that the question is relevant. Bearing in mind, I suppose, that science doesn't always know what's really going to be relevant. I mean, sometimes it is, a fairly straightforward thing about putting treatments together and assessing outcomes and side effects, but occasionally we just don't know what might come out of it, and that can mean things like taking additional samples and storing them in a biobank. And who knows, 5 or 10 years later, there might be some kind of burning scientific question about the biology of CLL that really can only be answered if you've got those cells stored. Does that go some way? You've probably got more.
Oh, well, I do have more. So yeah. On the bottom of this slide, it says is shaped by potential participants for participants, but you say ensure dignity and safety and well-being protected at every turn. How do you do that? How do you ensure dignity and safety for the participants? And if participants are feeling uncomfortable at any stage, what can they do something about that?
Yeah, I mean, absolutely. And I think that goes to the heart of it. As I said before, the idea of medical research and studies is to make life better, and therefore research should make life better as well. And so a number of things from this. I think Nick alluded to things like the Declaration of Helsinki and making sure that there were checks and balances in place. Getting the risk and the benefit in balance, and a good PPIE group, I think, will help with that. So, for example, bone marrow tests, that's not a particularly nice thing to have. So, what if a study said, oh, we're going to do a bone marrow test every 3 months or after every round of treatment? I mean, it just wouldn't be reasonable. And if there was a sample that you could take that was a blood test, so for example, for increasingly things like MRD, looking at really low levels, can be done with a blood test. So if you can substitute something simpler, less intrusive, less invasive, then that's a good thing, and that can be built into the design. So at a really early stage, there might be simple things. Jackie was talking about traveling to London for a study, staying overnight. So, is there accommodation? Are you going to be looked after? Will you be fed? Simple things like that. Just making sure that you're okay. And if it's uncomfortable, if it's not the right thing for you as a participant, as a patient, as a person within a study, then there is always that ability to walk away.
Well, I think that's fine. If participants can walk away, then I think that answers that question. Thank you.
Yeah. So absolutely, and it should be written into the informed consent forms as well. There'll be a little paragraph saying you can change your mind. If you don't have to give a reason, you don't have to justify it, and your normal care will not be prejudiced from it. In other words, just because you say, I don't want to be in this study, doesn't mean that you won't be looked after. You'll receive all the normal care that you would normally receive. So there shouldn't be any prejudice to your normal care for entering a study. And that's something a PPIE group can check, but it will be built in. I'd be confident of that, but it's always worth checking. Just kind of bearing in mind that sometimes, the data or the samples collected up until that point where you say, okay, this is not for me, that they're usually, that you can analyze up to that point, partly because samples might be anonymized and you can't trace them. It might be as simple as that. So there are, some extra bits around it, but, the basics are that you don't have to justify and you get your normal care. So essentially, the benefits of PPIE are multiple. They're really manifold. So you can improve the quality and the relevance of the research. We talked about that. You can improve the recruitment, because if a PPIE group reviews the information, the patient information sheets, the booklets, the websites, the videos, the pamphlets, whatever might be there as supporting information, and they can ensure that it's clear, transparent, and hopefully translated into other languages, that it's going to be broadly acceptable, understandable, and open and transparent to everyone. So you'll be able to recruit people. And then, of course, retaining people in the study, if there are no unpleasant surprises, in other words, the participants have been able to make an informed decision about things to begin with, then they're more likely to stay in the study because it doesn't come with surprises. So the selection of participants, it can be enhanced so that you're not limiting to gender groups, age groups, or biasing for risk groups or something like that. So you have a broad selection of people. And a PPIE group will hopefully have fairly diverse perspectives, and you just don't know what's going to fall out of that. There may be some very helpful suggestions for researchers who want to take those on board. And then you've got this whole thing of trust and transparency. And occasionally when I'm talking to people that, nobody wants to be a guinea pig. Nobody wants to think they're being experimented on. And clinical studies are simply not like that. It's very, very different. And this is all about people understanding what their options are and knowing that they have a standard treatment, a standard of care, and a clinical study as well, that they know what they're getting into. And that builds trust. And sometimes these things can be introduced at a fairly early stage in those conversations with people during maybe the active monitoring stage. So I think that sort of explains how the benefits might work. Have you got any issues or questions around?
There was just one question I had,
Yeah.
which I think you've partly answered, but I was going to ask how are participants recruited into clinical trials or research or other studies, and is it different if they're going through clinical trial versus other studies? By other studies, I mean something like the effect of exercise on your well-being.
Yeah, no, that's really good because, if it's something like a treatment-related study, then it's really likely you're going to be recruited through a specialist clinic. So a hematology clinic where you speak with the team, your consultant, and the idea of some kind of new treatment or treatment comes up, and then you're told, well, gosh, we've access to a clinical study if you're interested in that, and then that goes sort of through down that process, but it'll be the same clinical team. It could be, for example, being involved in exercise or being involved in some kind of just attitudes or symptoms, fatigue, for example, and those might be more relevant to someone who has a long gap in between clinics and so wants to find out about it, and they may be advertised on websites. CLL Support website, for example, might say, give some signposting to say, look, there's this available, or they may be approached directly from the clinical team, knowing that they are a patient on an active monitoring program and their appointment isn't coming up, but they may be interested in this particular study. So they might be called by a research nurse, for example. So different ways of doing it, I guess. Yeah. How and when does a PPIE group? So before the research, we've talked about some of the sort of design aspects and making sure that the information sheets and the consent forms have got all the bits that are right and are understandable, because you can bet your bottom dollar if there's jargon in there that is poorly explained, and if it's not clear to a PPIE group, well, it's not going to be clear to any of the participants either. So I think those things can be nipped in the bud and clarified very, very quickly. During the actual research process itself, there are different bodies that look at it. So, for example, there's a trial management group. Usually it's the interested clinicians involved with some other representatives, but there may be PPIE, there may be patient advocacy groups on those trial management groups. And they're looking at data safety, they're looking at toxicity, they're looking at side effects, they're looking at the benefit, and trying to analyze at critical time points, is this study going in the direction that we want it to go? Are we recruiting enough people? Are we seeing particular problems that we need to highlight? Are we actually seeing the benefits that we're looking for? So the statisticians might be interested, for example. And then going through it, it's quite common to have an interim report. So a paper could be presented at one of the big meetings, whether it's a national meeting or an international meeting, and those things, they're not always translated into a plain English report or a summary that could be hosted on a website. And I think it would be so helpful if PPIE groups could be involved in helping researchers to put some of those reports into plain English, so that the participants and potential participants and the CLL community can see the value of what's happening. And then after the research, clearly there's a body of work around disseminating the results and making sure that those results are understandable to people. Otherwise, it all disappears into the dim and distant past, and the community itself that wants to be so engaged in the research is not having that feedback. And I think that's one of the things that over the years we've really not been that good at. And I really, would love to see the PPIE being part of completing that loop where the results of studies can be communicated well to everyone involved.
I guess that bit is still evolving then, the dissemination of the results. But how can PPI participants contribute to that? Is it through patient networks and patient groups, and maybe even presenting at or co-presenting at other places?
I think there'll be a really exciting opportunity to do that. CLL Support, for example, does regular roadshows and with patients and patient groups up and down the country, and those are good opportunities. Those are great opportunities for patients themselves, participants themselves, to explain what happened in the study and how it happened. I think there's an open opportunity in some of those big meetings as well that we don't often see. Patients and participants contributing, alongside and in parallel. Maybe that's something that will change over time. But I think certainly in terms of, looking at summaries and plain English summaries, hosting those onto the relevant websites, I think that's a big win, and that's really open, I think. So yeah, it's a role to play in that space, and that's not difficult because it's all about just having a sense check on it. What's it trying to say? What does it mean? A small point about communication here, because I think the researchers themselves are responsible for this. The PPIE group is not responsible for ensuring that things are understandable. The researchers are, and they can be held to account by the PPIE group. And if something doesn't make sense to you, and there's jargon and it's too much technical stuff and it's not in context and it's not explained, then just keep hammering away until it is explained and it is clear. And I think that's where the role of the PPIE group is. And I think a large part of this is about empowering those of you who are attending this to say, yes, you can do that. Not only are you allowed to do that, you're encouraged to do that, and to ensure that things are written clearly. So it's not about technical knowledge, it's about ensuring that that communication of understanding is cascaded correctly. So yeah, I mean, we've talked about trials management groups and the early trial design group. So I think this is something that again it must be in evolution, but ways of getting into the identifying smaller numbers of people from the PPIE group, larger PPIE group, and thinking about how and who could be involved in working with researchers to design the study and to comment on the design, making sure that it's proportional and safe and relevant, and that the ethical review, so the review of the patient information and the consent forms are correct, that patient and participant information is clear. So working with potentially with funding bodies as well, so that understanding what pharmaceutical companies might want to ask in terms of relevant questions for the drugs that they're developing. Later on, groups like NICE that consider the results of clinical trials and have a fundamental role in funding the use of drugs in the UK. And so patients and advocacy groups are often asked to be part of that, to review things, to give their experience of a drug and of a treatment. And it could be that members of the PPIE group could be, would be welcomed into that to contribute to that process of funding approval. I think there's a typo here. So groups involved in the trial conduct. So I think it's all about trial conduct and dissemination. So trials management groups, and lobbying. What's changing things at a bigger scale, and looking for funding, looking for asking the regulators about licensing, and ensuring that when a study is done well, that it's going to be more powerful and more relevant to regulators so they can see more clearly the effects that it has on people. And if a study is well designed, it's going to pick up those side effects more effectively than it otherwise might.
Ben, we've just got some slides very briefly where you can talk to some more resources that we've got before we go on to our Q&A.
I think so. I'm just going to rattle through these really quickly in that case, because this is just about signposting. So next slide. So the integrated research application system, this is really all about how researchers sort of populate a web-based system to ensure that they've got all the documents and things in there, the protocol and the information sheets and things. So that's sort of the business end that technically a PPIE group doesn't really need to know about, but it's the structure within which research works. I think the key documents to look at are information sheets, and they should cover everything. It should be clear. You should know what's going to happen, why it's going to happen, who is going to do it to you, what the process is, how long it's going to take, how many times. And if you look at this and think, oh, that procedure is a bit repetitive, or it's painful, or it's inconvenient, or something else undesirable about it, you can challenge it and say, can we have fewer of those? Can we have fewer bone marrows, please? Can we have fewer blood tests, fewer scans? That always goes down well with us in the research committees when we see that every effort's been made to make life easier and less uncomfortable for participants. All about proportionality. The informed consent form will be broken down into separate paragraphs, and it should have things like, you've had enough time to consider it, you've asked all your questions, and you can withdraw at any time. And each paragraph should be separately agreed to and usually signed for with initials. And there may be some optional add-ons as well, typically about biobanking and collecting extra samples. I mean, I'm just going to signpost this. There is quite a lot out there, but in terms of trusted resources, the NIHR, you can't go wrong if you have a look at this. So there are many resources and quite a number of pages through the NIHR, which you can really have a good look at. Lots of homework to do. So go and enjoy those. I think they're well worth a read and really helpful. Yeah, I think that's just says basically the same thing.